Welcome to the Deep Dive. Today, we're really going into one of life's most incredible journeys, pregnancy. And for you, listening as future BSN-level nursing professionals, well, our goal is to shed light on your crucial role, making sure two lives aren't just surviving, but actually thriving. So the big questions are, how do we, as healthcare providers, get those really deep, critical insights into what's happening? And what do we do when things get complicated?
It's a huge topic.
It really is. This deep dive is specifically for you, aiming to give you, well, a shortcut to being genuinely well-informed in this critical area of nursing. We'll unpack prenatal diagnostic tests, fetal assessment tools, and yeah, the sometimes really challenging landscape of pregnancy complications.
And what's truly amazing, I think, is just how far we've come. Understanding maternal and fetal health, it's night and day compared to even a few decades ago. So this isn't just about what tests we do or what problems can pop up.
Right.
More importantly, we want to explore why these things matter and really underscore your unique, pivotal role in guiding families. You'll be with them during some incredibly vulnerable and hopefully also very joyous moments.
Absolutely. Our source material for this is really comprehensive. It covers the basics, the foundations of testing and assessment, then drills down into specific tools, think ultrasound, CVS, amnio, and then we pivot. We look at common, often tough pregnancy complications, things like hemorrhagic conditions, bleeding early on, bleeding later, and a whole range of infections too.
And throughout all of it, the connecting thread is the nurse's role. It's absolutely vital, connecting the science, the tech, to the very human experience of it all.
Exactly. Providing safe, person-centered care is the name of the game.
Precisely. So as future nurses, the challenge for you is always asking, how can I effectively monitor? How can I educate? How can I truly support families during these crucial, life-changing times?
Okay, let's start with the big picture. How has prenatal care changed? Because it really has transformed dramatically, hasn't it?
Oh, incredibly so. It wasn't that long ago, really, that the main questions were pretty basic. Is the fetus alive? Check. Growing okay? Check. What's the position? Is there enough fluid? Those were sort of the headline questions.
The fundamentals.
Exactly. But now, with advances in science, in technology, the landscape is completely different. We've moved into this era of, well, incredible precision.
So what does that precision allow us to do now?
Well, it means we can confirm fetal well-being with much more detail. We can screen for really complex things, genetic issues, structural problems, chromosomal abnormalities, and we can make diagnoses much earlier and much more accurately.
And the why behind that is crucial, isn't it? Early detection.
Early detection makes a massive difference. It often translates directly into better outcomes. It gives families and the whole care team time to plan much more effectively. Maybe that means planning for specialized care right after birth, or sometimes it helps families make those really difficult, deeply personal decisions about the pregnancy's path forward.
And this brings us squarely to the nurse's role, which for you as BSN students is so much more than just looking at a test result on a screen.
Absolutely.
Yeah.
It's not just data interpretation.
No, it's about creating this whole environment, right? An environment of communication, of support, and crucially, shared decision-making.
Yeah.
You're the one building that trust, that relationship, often during really anxious times for parents to be.
You've nailed it. The nurse's responsibilities are just so central to modern OB care. You're coordinating care, making sure appointments happen, results get communicated clearly, sensitively. You're often the main educator.
Translating the jargon.
Exactly. Translating medical speak into something people can actually understand so they feel empowered, not confused. And then there's the emotional reassurance. That's huge, especially when there's uncertainty or stress. You really are the bridge.
Yeah, that bridge between complex medical stuff and the very real human needs of the patient and their family, making sure they feel informed, heard, included in every single step. Okay, so let's clarify something fundamental, because this can trip people up, patients, and even providers sometimes. The difference between screening tests and diagnostic tests.
Yes, this is critical for good communication and, honestly, for preventing a lot of unnecessary worry. Let's break it down.
Okay.
Screening tests. Their job is to estimate risk. They flag individuals who might have a higher chance of a certain condition. Think of it like a first pass, a filter.
Not a definite answer.
Definitely not.
Yeah.
They aren't 100% accurate. You get false positives, the test says high risk, but the baby's fine. And false negatives, the test misses something that's actually there. Mostly, these are blood tests, serum analyte screens, and getting the timing right, the gestational age, is super important for accuracy.
So, like, a blood test suggests a higher risk for Down syndrome.
but it doesn't confirm Down syndrome. The baby might be born completely without chromosomal issues. It's just a probability and estimated risk.
Got it. So then diagnostic tests.
Diagnostic tests are different. They aim for more precise, often yes or no answers about a specific condition. We usually do these after a screening test comes back abnormal or high risk, or maybe if there are other red flags like family history or advanced maternal age.
And these can confirm things?
Yes, diagnostic tests can definitively confirm chromosomal issues, specific genetic disorders, or structural problems.
Mm.
The classic examples here are things like chorionic villus sampling, CVS amniocentesis, and PUBS, which is percutaneous umbilical blood sampling.
Okay, let's try an analogy to make this stick, especially for you nursing students. Think about mammograms versus biopsies for breast cancer
Hang
screening.
on.
A mammogram is the screening tool, right? It looks for suspicious areas, things that might be a problem, but if it finds something,
You don't automatically get diagnosed with cancer.
exactly, you move to the diagnostic test, the biopsy. That's what gives the definitive yes or no answer. Same idea here in prenatal care. Screen first to estimate risk, then diagnose for confirmation if needed.
Perfectly put. Understanding that sequence is key.
Now, with all these options, why do people actually choose to do these tests? What are the motivations? Because it can be stressful waiting for results.
That's a really insightful question. The motivations are diverse, very personal. For many, it's about reassurance. Normal results can lift a huge weight, let them enjoy the pregnancy more.
Makes sense.
If the results do suggest an issue, well, testing gives families crucial time to prepare. That could mean learning about the condition, meeting specialists, finding support groups, planning for special newborn care.
Getting ready for what's ahead.
Exactly. In some situations, though less common, the results might inform really tough decisions about continuing the pregnancy. And finally, if a baby needs highly specialized care right at birth, prenatal diagnosis allows planning for delivery at the right hospital, with the right team ready to go. It's all about information for planning, whatever that plan might look like.
And it's so important to stress, certainly here in the US, these genetic tests are offered routinely even, but they're always, always voluntary.
Absolutely.
Yeah.
100% voluntary.
Patients have the right to say yes or no based on their own values, beliefs, culture, whatever feels right to them. It's truly about informed choice.
And that is where the nurse becomes so central. Your job is providing unbiased, non-directive counseling. You're not there to push them one way or the other.
Right.
You explain the purpose, the benefits, the limitations neutrally. You make sure they understand everything before they consent. And you absolutely respect that there's no single right or wrong choice here. It's personal. When patients feel informed, heard, supported, they feel empowered to make choices that align with their goals.
So stepping back, the overall nursing role in prenatal testing, it's massive. You're involved at pretty much every stage.
That's right. We're integral. We educate families, what tests are for, what to expect. We help schedule things. Sometimes assist directly with procedures like ultrasound or amnio. Emotional support is constant before, during, after. Because it is stressful. We help interpret results, translate them, help patients formulate good questions for their doctors or midwives. We really are that compassionate bridge between complex medicine and the patient's need for clear, supportive guidance.
Okay, let's dive into some specific tests now, starting with probably the most common and often the most exciting for parents. Ultrasound. It's more than just a medical test for many, isn't it? It's that first, hello.
It really is special. Seeing that heartbeat flicker, the baby's profile, it's a powerful bonding moment. Medically, how it works is using high-frequency sound waves. They bounce off tissues, creating real-time images. It's non-invasive, usually painless, and considered safe when done for medical reasons. We always use the lowest possible settings, Al-Ari principle.
Right, as low as reasonably achievable.
Exactly. But it's important to manage expectations. The results aren't perfect. Image quality depends on the machine, the person doing the scan, even just how the baby's lying. Sometimes they're just not cooperating for that perfect picture.
Huh, yeah. And you mentioned different types of ultrasound.
Right. So the standard black and white images, that's 2D, most common. Then you have 3D, which adds depth. Makes it easier to see structural things like maybe a cleft lip. Gives a more lifelike image.
Okay.
And 4D takes it further. It's like real-time video. Parents can actually watch the baby move on screen. Kicking, stretching. It's pretty amazing for bonding.
And the timing matters too, right? When the ultrasound happens affects how it's done and what you're looking for.
Absolutely. Early on, first trimester, say up to about 14 weeks, we usually do it vaginally, with a special probe. Gets much clearer images then because it's closer to the uterus.
And the goals then are?
Confirm viability,
Yeah.
see that heartbeat, get an accurate due date, measure the crown rump length, check if it's twins or more, and just look at the general pelvic structures, uterus,
Okay.
ovaries.
Then later on, second, third trimester.
Then it's usually abdominal. That's often when the big anatomy scan happens, around 20 weeks usually. It's really detailed. The provider looks meticulously at all the organs, bones, checks growth, estimates age if needed, looks at amniotic fluid levels, finds the placenta's location, making sure it's not blocking the exit.
So sent a previa check.
Right. And figures out the baby's position, head down, breech, etc., getting ready for birth.
So as nurses, what's our role during an ultrasound beyond just, being there? What are the key things we do?
Oh, our role is vital. We help prepare the patient, physically and emotionally, ease their anxiety. For instance, early scans often need a full bladder to lift the uterus.
Which can be uncomfortable.
It can. So the nurse explains why it's needed, makes it less of a chore. We help with positioning for comfort and best images, provide reassurance, answer questions. In some high-risk areas, specially trained nurses might even do limited scans themselves, like checking fluid levels for a biophysical profile, within their scope, of course.
So it's both diagnostic and emotional.
Totally. It's a diagnostic test, absolutely, but also a huge emotional milestone. Nurses enhance that experience, prepare people, explain limitations, offer support, especially if any concerns pop up.
Okay, moving from diagnostic tools like ultrasound back to screening. We said these estimate risk don't give a definite answer. They flag people who might need diagnostic follow-up like CVS or amnio.
Exactly. And you, as the nurse, will constantly be reinforcing that distinction, preparing clients, explaining results, supporting them through the waiting. It can be nerve-wracking.
So what's one of the earliest screening options?
That would be first trimester screening, or FTS. It's a combo deal, an ultrasound plus maternal blood work, usually done between 10 and 14 weeks. The ultrasound looks specifically at neutral translucency, the NT measurement.
That's the fluid at the back of the baby's neck.
Right. A thicker measurement, say over 3.0 millimeter, can be linked to things like trisomy 21, Down syndrome, or even heart problems. Then the blood work checks two proteins, PPA and HCG. Patterns in their levels can also suggest certain chromosomal issues.
But again, it's just a risk estimate.
It's just an estimate, not diagnostic. False positives, false negatives happen. An abnormal FTS always needs diagnostic confirmation.
Okay. And then there's the newer kid on the block, the one that's really shifted things.
Yeah.
Cell-free fetal DNA screening. NIPS? Sounds fancy. How does that work?
It is pretty revolutionary. It analyzes tiny bits of fetal DNA that are actually floating around in the mother's bloodstream. Came from the placenta, mostly.
Just from a regular blood draw.
Yep, just a standard blood draw from the mom. Safe, non-invasive, huge plus. You can detect this DNA early, maybe 5-7 weeks, but it's most accurate after 10 weeks.
And what does it screen for?
The common trisomies, 21, 18, 13, sex chromosome issues, even some smaller things like microdeletions. Its big advantage is really high sensitivity and specificity for trisomy 21 compared to the older screens. Much better at picking it up and much better at ruling it out correctly.
But it's not perfect either, right? What are the limitations nurses need to know?
Crucial limitations, yes. It does not detect structural things, like neural tube defects, spina bifida. That needs ultrasound or AFP testing. Also, only a small fraction, maybe 3 to 13%, of that cell-free DNA is actually fetal. So false results can still happen.
Okay.
It's also less reliable sometimes, like with vanishing twin syndrome or certain multiple pregnancies. And the absolute key takeaway, a positive cfDNA result is still a screening result. It always needs confirmation with a diagnostic test like CVS or amnio before any irreversible decisions are made. Still screening, not diagnostic.
Got it. So what if first trimester screening or cfDNA points to higher risk, or maybe those weren't done? What's next in the screening pathway?
Then you often move to second trimester, multiple marker screening,
Yeah.
usually called the quad screen. Done later, between 15 and 22 weeks, but most accurate around 16, 18 weeks. Another blood test.
We're looking at different things this time.
Yep, 4 specific markers, usually. HCG again, alpha-fetoprotein or AFP, unconjugated estriol, UE3, and inhibin A. AFP is a big one here. Elevated levels are strongly linked to open neural tube defects like spina bifida. Sometimes they add a 5th marker, then it's a pentascreen.
And interpreting this sounds complex.
It is quite complex. It's not just the raw lab values. The risk calculation factors in the exact gestational age, mom's weight, ethnicity, if she has diabetes, if it's twins, all these variables matter.
Like baking, need the right ingredients in the right amounts.
Exactly. And AFP levels especially need attention. High AFP might mean neural tube defects, yes, but also abdominal wall defects, or maybe it's just twins or sadly, fetal demise. Low AFP could suggest trisomy 21, or maybe the dating is just off.
So again, the nurse's role in guiding patients through these screenings.
Yeah.
What's the most important thing for new nurses to grasp here beyond the technical details?
That's a great way to put it. Beyond the technical, it's the human side.
Yeah.
What new nurses sometimes underestimate is the sheer emotional weight these results carry. It's not just data. So, key nursing roles. Constant educations. These are risk assessments, not diagnoses. Reinforcing the need for confirmation if results are abnormal. Providing that crucial emotional support, acknowledging the stress of waiting, the fear of a high-risk label. Ensuring timing is right for accuracy. Facilitating referrals to genetic counseling. Remember, these results can cause huge anxiety. Your job is to clarify, explain the next steps, and reassure families that many abnormal screens don't end up confirming a problem.
Okay, so screening flags a potential issue. Or maybe there's another strong reason to need a definitive answer. Now we move to the diagnostic tests. These give the yes or no, but they're invasive, carry some risks, and definitely ramp up the emotional stress.
That's exactly right. These procedures involve directly sampling fetal tissue, amniotic fluid, or fetal blood. They give certainty about chromosomal, genetic, or metabolic conditions. And nurses are absolutely vital here, preparing clients, supporting them emotionally, coordinating everything. The main ones are CVS, amnio, and pubs cordocentesis.
Let's start with CVS chorionic villus sampling. When is that done?
CVS is done earlier, usually between 10 and 13 weeks. The big advantage is getting that early diagnosis, giving families more time.
And what exactly are they sampling?
Chorionic, villine, tiny finger-like bits of the placenta. They're the same DNA as the fetus. The sample's taken either through the cervix with a catheter or through the abdomen with a needle, always under continuous ultrasound guidance for safety.
How long for results? And what are the risks?
Full results take about 5-7 days. Sometimes you can get a faster preliminary result, FISH analysis, in 24-48 hours, but that's not the final diagnostic word. Risk-wise, there's about a 1% chance of pregnancy loss, maybe lower with experienced hands. Cramping, spotting can happen, especially with the surgical approach. Rare stuff includes infection, hematoma, or rupture of membranes.
And the nursing care for CVS?
Teach about the procedure, recovery, reassure that mild cramping spotting is common. Instruct rest for 24 hours, avoid sex, heavy lifting for a few days, tell them when to call heavy bleeding, severe pain, fever, fluid leak, clots. And absolutely critical, make sure Rh-negative clients get RhoJam afterwards. Non-negotiable.
Okay. Then amniocentesis. Probably the one people have heard of most. How's it different from CVS?
Amnio is done later, usually 15 to 20 weeks. It's the go-to for confirming chromosomal or genetic issues flagged by screening. Can also check for fetal infections, investigate losses, manage fluid disorders. Used to check lung maturity, but less common now.
And the procedure itself.
Ultrasound finds a safe pocket of amniotic fluid. Then a thin needle goes through the abdomen, sterile technique. Discard the first bit of fluid to avoid mom cells. Then collect about 20 millimol, all under continuous ultrasound. Risks are low, less than 1% loss rate usually. Mild cramping, spotting, maybe a tiny fluid leak can happen. Rare risks. Infection, needle injury.
Nursing role for amnio.
Help with positioning, handle the specimen correctly, reassure about common mild symptoms, instruct rest for 24 hours, then usually back to normal activity, teach the warning signs, continuous fluid leak, heavy bleeding, bad cramps, fever, decreased fetal movement, call immediately. And again, absolutely ensure Rh-negative clients get RhoJam. Vital check.
Right. And the third one, PUBS, or cordocentesis. Percutaneous umbilical blood sampling. Sounds intense. When is that used?
It is more invasive, yes. PDS means directly accessing the fetal bloodstream via the umbilical cord. Used less often now, but still crucial in specific high-risk scenarios.
Like what?
Like diagnosing or managing severe fetal anemia, maybe from Rh incompatibility, and even doing an intrauterine blood transfusion right through the needle. Also used sometimes for diagnosing infections, certain genetic things, or giving meds directly to the fetus, like heart rhythm drugs.
Wow. And how's it done?
A fine needle is guided by ultrasound directly into the umbilical vein. Gives immediate access to fetal blood.
But higher risks, you said.
Definitely higher risks than CVS or amnio. Things like bleeding or clotting at the cord puncture site, fetal heart rate slowing down, bradycardia, infection, preterm labor, even pregnancy loss.
So nursing care here is even more critical.
Absolutely. Intensive education and emotional support beforehand are key. Very close monitoring of mom and baby's heart rate afterwards. Reinforcing those warning signs, report any bleeding, contractions, fever, decreased movement right away. Your assessment skills are paramount.
It's so clear that all these diagnostic tests, while giving vital info, happen during such stressful times. How do nurses best support families navigating these choices, waiting for results that could change everything?
You hit right there. The stress is immense, especially if results might lead to tough decisions. Nurses provide that critical support. Clear explanations, realistic expectations about results, reassurance that knowing helps guide the safest care plan no matter the outcome. We're their constant support. Just listening, validating their feelings, that's powerful nursing care in itself.
Yeah. Still, even with the best tests, things don't always go smoothly. Complications can arise. And understanding these complications, the signs, the management, the support needed is just as vital for nurses. So, when things take an unexpected turn, we're talking about health issues that could threaten mom, baby, or both. What does that really mean for us as nurses?
It means being vigilant. Pregnancy complications or any health issues during gestation that pose a risk. Some are common anemia, gestational diabetes. Others are rarer but more serious, major bleeding, severe infections. They can pop up early or late.
Like bleeding problems often show up early.
Right, miscarriage,
No.
ectopic pregnancy. Those often happen before 20 weeks. Then you have pre-existing conditions, maybe lupus, thyroid issues that can complicate things throughout. And infections pose risks anytime. The nurse's job. Recognize warning signs, understand the why, know the interventions, provide safe, supportive, compassionate care, often when families are scared or grieving. Let's focus first on bleeding, specifically in early pregnancy.
Okay, bleeding early on, that has to be incredibly frightening for parents. Our source highlights three main culprits before 20 weeks: miscarriage, ectopic, and GTD. And for nurses, the focus is always assessment, stabilization, emotional support, and education. Right?
Absolutely. Let's break those down. First, spontaneous abortion or miscarriage. Loss before 20 weeks. Sadly, it's the most common complication.
Yeah.
Maybe 15–20% of known pregnancies.
Causes can be varied.
Very varied. Chromosomal issues are common.
Mm.
Infections, hormone problems, uterine structure issues, often though the cause is unknown, which can really amplify feelings of guilt. Your empathy here is just crucial.
And miscarriages present differently.
Yes, a threatened abortion means bleeding, but the cervix is closed, pregnancy might continue. Inevitable means the cervix is open, loss is happening. Incomplete means some tissue passed, some remains. Complete, everything passed. Missed abortion is tough, the fetus died but is retained, so the loss isn't physically complete yet. And recurrent is 2 or more consecutive losses, often needs investigation.
Yeah.
Ultrasound confirms viability or retained tissue. Monitor beta-HCG levels, maybe a D&C if tissue is retained, and always ROGAM for Rh-negative clients. Nursing focus. Monitor bleeding, vitals. Provide huge emotional support, acknowledge grief, guilt, teach infection prevention, no tampons, no intercourse till cleared, stress follow-up care.
Okay. Then ectopic pregnancy, that sounds like a true emergency. Red flags for nurses.
It is an emergency. Fertilized egg implants outside the uterus, usually the fallopian tube, if it ruptures. Life-threatening hemorrhage, big cause maternal death in the first trimester.
Risk factors.
History of pelvic inflammatory disease, PID, tubal surgery, previous ectopic, IUD use, smoking, IVF.
And the classic signs.
Missed period, positive pregnancy test. Unilateral, lower abdominal pain, vaginal spotting, or bleeding, if it ruptures. Sudden, severe pelvic pain, sometimes referred shoulder pain from internal bleeding irritating the diaphragm, and signs of shock, fast heart rate, low BP, dizziness. Surgical emergency.
Diagnosis and management.
Transvaginal ultrasound, serial HCGs. If caught early, tube intact, maybe methotrexate medication to dissolve the pregnancy. If ruptured or bleeding heavily, immediate surgery, maybe try to save the tube, salpingostomy, or remove it, salpinectomy. Nursing focus. Prompt recognition of rupture signs. Monitor for shock. Give IV fluids, blood, huge emotional support. It's a crisis and a loss. Methotrexate teaching. Avoid alcohol, folic acid, NSA aches.
And the third early bleeding cause, gestational trophoblastic disease or molar pregnancy. That sounds unusual.
It is rare, but serious. Abnormal tissue proliferates instead of a normal placenta. Looks like grape-like clusters. Key signs: vaginal bleeding, often dark brown, prune juice color, uterus measuring larger than dates, no fetal heartbeat, very high beta-HCG levels, often severe nausea vomiting from the excess HCG.
How is it managed?
Usually a suction D&C to evacuate the uterus. Then, critical follow-up. Monitoring beta-HCG levels closely for 6–12 months. Why? Risk of choriocarcinoma, a rare cancer. So effective contraception is essential during follow-up to avoid confusion with a new pregnancy. Nursing focus. Educate on the necessity of follow-up contraception. Provide support as a loss plus prolonged monitoring. Very stressful.
So putting it all together, a patient comes in with early bleeding. How does the nursing process guide your immediate actions?
First, assess thoroughly. Gestational age, amount, duration of bleeding, pain level, location. Vital signs, urine output, check labs for blood loss, infection. Then, care and teaching. Explain tests, procedures. Teach infection prevention pads only. No intercourse, hygiene. Watch for fever, discharge. Encourage good nutrition, hydration, especially iron-rich foods. And the emotional piece is just as vital. Acknowledge the shock, sadness, guilt. Listen actively. Reassure it's not their fault. Offer grief resources. Finally, stress follow-up. For molar pregnancy, that's the HCG monitoring. For recurrent loss, maybe genetic counseling. It's a package. Monitor, teach, support emotionally, ensure follow-up. Physical and emotional recovery.
Key takeaways for early hemorrhage. Miscarriage, ectopic, GTD are main causes. Assessment first. Care involves stabilization, infection prevention, teaching, and compassionate support for the loss. Okay, now bleeding in the second half of pregnancy. This signals potentially much more serious issues for both mom and baby, demanding rapid action.
Absolutely. Late pregnancy bleeding carries higher stakes. Massive blood loss is a real risk. The two big players here are placenta previa and placental abruption. Both are true OB emergencies, needing fast assessment, close monitoring, and coordinated care.
Let's take placenta previa first. What is it, and how does it typically present?
Previa means the placenta implanted too low, partially or completely covering the cervix. The classic sign is sudden onset of painless, bright red vaginal bleeding in the second or third trimester. The uterus usually feels soft, relaxed, non-tender. Baby might be in an abnormal position, like breech, because the placenta is in the way down low.
Diagnosis and management.
Ultrasound confirms the placental location. Management depends on the amount of bleeding, how far along pregnancy is. Could be bed rest, steroids for fetal lung maturity if preterm delivery seems likely. If bleeding is heavy or it's a complete previa, it's usually a C-section. And the absolute critical nursing point, never ever do a vaginal exam if you suspect previa. You could cause catastrophic bleeding.
Okay, vital point. Nursing focus for previa.
Meticulous monitoring bleeding amount, fetal heart rate, maternal vitals. Prepare for a potential C-section. Provide lots of emotional reassurance. Teach about activity restrictions if they're on bed rest.
Got it. Now, placental abruption sounds more urgent, maybe more painful.
It is often more painful and definitely an emergency. Abruption is when the placenta prematurely separates from the uterine wall before birth. Clinical signs are different from previa, usually painful, dark red vaginal bleeding. But sometimes the bleeding is concealed, trapped behind the placenta.
So you might not see much blood.
Exactly. But the uterus will feel firm, rigid, and very tender. Fetal distress is common on the monitor. Mom can go into shock quickly from blood loss, even if it's hidden.
Diagnosis and management for abruption.
Mostly clinical diagnosis based on those signs, though ultrasound might help confirm. Immediate goal is maternal stabilization. IV fluids, maybe blood products, continuous fetal monitoring. Prompt delivery if the abruption is severe. And watch out for DIC, disseminated intravascular coagulation, a serious clotting problem that can happen with abruption.
Nursing focus in an abruption.
Frequent vitals, continuous fetal monitoring. Be hyper-aware of concealed bleeding signs, worsening pain, rigid uterus, shock signs without heavy visible bleeding. Prepare for rapid delivery, potential transfusion, and provide that crucial emotional support during a very scary emergency. Quick, decisive action is key.
So, key takeaways for late hemorrhage. Previa, usually painless, bright red bleeding, soft uterus. Abruption, usually painful, dark red bleeding, rigid, tender uterus. Both are high-risk emergencies needing rapid intervention. Nursing priorities, intense monitoring, stabilization, preparing for delivery, and constant support. Okay, we've covered those acute bleeding emergencies, but other medical conditions, even chronic ones, can significantly impact pregnancy too, right? Even if they aren't sudden crises.
Absolutely. Conditions like anemias, autoimmune diseases, endocrine issues, seizure disorders, they might not cause sudden drama like a hemorrhage, but they exert a chronic influence, impacting maternal health and fetal development throughout the pregnancy if not managed well. Let's start with anemias. They're pretty common.
Right. What's the main issue with anemia in pregnancy?
Basically, reduced red blood cells mean less oxygen delivery to mom and baby. Most common type is iron deficiency, but folate deficiency, B12 deficiency, sickle cell disease also occur. Anemia is linked to preterm birth, low birth weight, and makes dealing with blood loss at delivery riskier.
So, iron deficiency anemia. What are the signs and management?
Mom might feel fatigued, look pale, have a fast heart rate, headaches, maybe that weird craving called pica, like for ice or dirt. Baby's risk is preterm birth, low birth weight. Management is iron-rich diet plus ferrous sulfate supplements. Vitamin C helps absorption.
And folate deficiency. That one's linked to.
Neural tube defects, like spina bifida. Folic acid needs actually double in pregnancy. Deficiency can come from poor diet or carrying multiples. Results in megaloblastic anemia, large immature red cells. Management is daily folic acid supplements, sometimes higher doses. B12 deficiency also causes megaloblastic anemia, managed with B12 injections.
What about sickle cell disease? That's a genetic condition.
Yes, abnormal hemoglobin causes red cells to sickle, leading to chronic anemia, higher infection risk, and those really painful sickle cell crises, often triggered by low oxygen, dehydration, stress. Pregnancy can unfortunately make these worse. For the fetus, risks include miscarriage, preterm birth, growth restriction, stillbirth.
Management sounds complex.
It requires close care. Preconception counseling is ideal. During pregnancy, focuses on hydration, good nutrition, rest, extra folic acid, preventing infections, treating fevers early, close fetal monitoring. During labor, oxygen and hydration are key.
How does the nursing process help manage these different types of anemia?
It starts with assessment. Identify risks, diet, multiples, history. Look for symptoms, fatigue, pallor. Check labs, HGB, HDT, iron, folate levels, understand diet, culture, adherence issues, common nursing diagnoses, fatigue, infection risk, knowledge deficit, planning goals. Client understands plan, follows diet supplements, reports warning signs, labs improve, interventions are key. Teach diet strategies, iron foods, meat, beans, greens, folate, citrus, fortified grains, vitamin C. Educate on taking supplements correctly. Encourage rest. For sickle cell, teach trigger avoidance. Monitor mom and baby closely with labs, visits. Collaborate with providers for transfusions if needed. Evaluation. Labs improve, fatigue lessens, client adheres, mom and baby stable.
Okay, beyond anemia, what about autoimmune diseases? How do they interact with pregnancy?
Autoimmune diseases where the body attacks itself can flare during pregnancy due to immune system shifts.
Right.
Requires careful monitoring.
Like lupus.
Right. Systemic lupus erythematosus. Increases risk for preeclampsia, preterm birth, growth restriction, miscarriage, stillbirth. A specific neonatal risk is congenital heart block. Key nursing point. Encourage getting SLE well controlled before pregnancy, especially kidney function. Close monitoring throughout is essential.
Thyroid issues too, Graves' disease and Hashimoto's.
Yes, Graves' is hyperthyroidism. Risks include preeclampsia, heart failure, thyroid storm, a life-threatening emergency, miscarriage, preterm birth. Fetus can also get thyrotoxicosis. Treatment is antithyroid meds. PTU first trimester, then methimazole usually. Nurses must watch for thyroid storm signs, sudden worsening of symptoms.
Yeah, Hashimoto's.
That's hypothyroidism. Untreated risks include miscarriage, preterm birth, preeclampsia, and importantly, potential impact on the child's neurodevelopment. Treatment is levothyroxine replacement, nursing focus, screen high-risk women, stress medication adherence, monitor thyroid levels.
What about seizure disorders, epilepsy? Medication seems like a big concern there.
It is. Epilepsy itself increases risks, miscarriage, hemorrhage, hypertensive disorders, abruption, preterm birth. And yes, many anticonvulsant drugs can cause birth defects, especially neural tube defects. But here's the critical nursing message. Continued anticonvulsant therapy is vital. Uncontrolled seizures are more dangerous than medication risks.
So keep taking the meds.
Yes, usually the lowest effective dose. Monitor drug levels. Strongly recommend folic acid supplementation. Teach safety like not bathing the baby alone. Educate about postpartum mood risks too.
And quickly, Bell's palsy. Less critical but distressing.
Yes, temporary facial paralysis one side. More common in pregnancy, difficulty closing eye, eating, speaking. Main nursing role is emotional support, teaching eye care like patching, drops, and reassuring them it usually resolves. It looks scary, so empathy is key.
Okay, shifting now to infections. You mentioned that silent danger aspect, mild for mom, potentially severe for baby.
Exactly. Pregnancy changes the immune system, changes the GU tract, makes people more susceptible. And some infections that are no big deal for the pregnant person can be devastating for the fetus, causing birth defects, growth problems, preterm birth, even death. Others increase mom's risk for sepsis or preterm labor. Nurses are key. Identify infections, promote screening, ensure treatment, teach prevention, and crucially, knowing which meds are pregnancy safe.
Let's run through some key infections, maybe focusing on that fetal impact and nursing considerations, like STIs.
Sure. Untreated syphilis
Right.
crosses the placenta, miscarriage, stillbirth, severe congenital defects. Treatable with penicillin, so early screening is vital, gonorrhea and chlamydia. Newborns can get severe eye infections, ophthalmia neonatorum, or pneumonia during birth. Linked to preterm birth, screen everyone, treat early with safe antibiotics.
What about herpes, HSV?
Biggest risk is neonatal herpes. Passed during vaginal birth if mom has active lesions. Can be localized or severe, systemic, even fatal for the baby. Management. Antiviral suppression, cyclover, starting around 36 weeks to prevent outbreaks. C-section of active lesions or warning signs at labor.
Okay, beyond STIs. CMV.
Cytomegalovirus,
Yeah.
common herpes virus, often asymptomatic in adults. Big risk factor for pregnant individuals is contact with toddler salivary and daycare workers. Take note. Fetal impact. Some are fine, but others get congenital CMV jaundice, big liver spleen, growth restriction. And importantly, CMV is the leading cause of childhood hearing loss. No cure, no vaccine. Prevention is key.
Meticulous hand washing.
Rubella, German measles.
Mild for adults, but devastating if contracted in early pregnancy. Congenital rubella syndrome, deafness, eye defects, heart defects, growth restriction, microcephaly, no treatment during pregnancy, prevention. Check immunity pre-pregnancy or early on. MMR vaccine postpartum, it's a live vaccine. Avoid exposure.
Hepatitis B, HBV. High transmission risk at birth if mom is positive, HBsAg positive. Most infected newborns become chronic carriers, risk of cirrhosis, liver cancer later. That's why all pregnant clients are screened. If mom is positive, newborn must get HBV vaccine, anti-hepatitis B immune globulin, HBIG, within 12 hours of birth. Critical intervention.
HIV.
Transmission risk used to be high, 15–40%, but with antiretroviral therapy, ART, throughout pregnancy, and avoiding breastfeeding in high-resource areas, risk drops below 2%. So universal screening, RT for positive moms, sometimes prophylactic RT for newborns.
Group B strep, GBS, that's a common one nurses deal with.
Very common. It's normal vaginal flora for many, but can cause serious newborn infections. Sepsis, pneumonia, meningitis. That's why we screen everyone with a vaginal rectal swab around 35–37 weeks. If positive, 5E antibiotics, usually penicillin, during labor. This dramatically reduces newborn GBS disease. You'll manage this frequently.
So, summarizing infections. Remember the silent danger. Mild mom, severe baby. Prevention is huge. Vaccines, hygiene, safe sex food. Screening is standard. Rubella, GBS, HBV, HIV. Timely interventions, antibiotics, antivirals, vaccines, C-section, protect the newborn. Your role is crucial in all of this. Okay, let's equip you with the specifics, the actual tools in your nursing toolbox, the medications you'll see used often for these complications.
Right, knowing these drugs is essential. Let's start with methotrexate, Terxel, used for medical management of early unruptured ectopic pregnancies. Stop cell growth, nursing considerations. Ensure patient is stable first. Teach side effects, nausea, fatigue. Critical teaching. Avoid alcohol and folic acid, they interfere. Monitor HCG levels down to 0.
Road D.
Immune globulin. Prevents Rh-negative moms from making antibodies against Rh-positive fetal blood. Given after potential mixing events, miscarriage, CVS, amnio, trauma, and routinely around 28 weeks. Also postpartum if baby is Rh-positive. Give IM within 72 hours of exposure. Vital for preventing hemolytic disease in future pregnancies. Acyclovir. Zovirax. Antiviral for herpes, HSV. Used to treat outbreaks or often suppressively starting at 36 weeks to lower chance of lesions at delivery. Teach adherence. Remember, C-section if active lesion symptoms at labor.
RRT for HIV.
Antiretroviral therapy. Combination drugs to prevent mother-to-child HIV transmission. Strict adherence is key to get transmission risk way down. Teach about side effects, importance of continuing therapy.
Hepatitis B vaccine and HBIG.
For newborns of HBsAg positive moms, both must be given within 12 hours of birth to prevent chronic HBV. Emphasize completing the full vaccine series later.
And penicillin for GBS.
Penicillin G or alternatives like cefazolin, clindamycin, vancomycin if allergic. For GBS positive moms during labor, reduces risk of newborn GBS disease. Stress that it needs to be given during labor to be effective for the baby passing through the birth canal. Timing is everything.
Okay, medications covered. Now, labs. You said understanding labs is like a superpower. They give those early warnings. What are the key ones nurses need to watch closely in these situations?
Absolutely. Labs give us that internal view. First, HCG, human chorionic gonadotropin. Early on, it should rise rapidly, doubling roughly every 2–3 days. If it's low or plateaus or falls inappropriately, think ectopic or miscarriage. Very high levels could be molar pregnancy, GTD. It's your early viability signal.
Hemoglobin and hematocrit.
HGB and HCT tell you about red blood cell mass, oxygen carrying capacity. Normal levels dip slightly mid-pregnancy due to more plasma volume, hemodilution, but generally HGB should be 11 first third try or a 10.5 second try. Low levels. Critical sign of bleeding miscarriage, previa, abruption. Guides need for transfusion, tells you if blood loss is significant.
H antibody screen.
The indirect Coombs test should be negative. If positive, it means mom has developed antibodies against Rh-positive blood. She's sensitized. Puts future Rh-positive babies at risk for hemolytic disease.
And just knowing the blood type and Rh factor. Fundamental. Done at the first visit. Knowing if mom is Rh negative is essential for triggering ROGAM administration at the right times, prevents that sensitization in the first place. These labs, taken together, help you monitor viability, stability, bleeding risk, infection signs, even point towards things like preeclampsia ALP. Indispensable tools for your assessment. Hashtag outro.
Wow, we have covered a tremendous amount of ground today, from the real sophistication of prenatal tests to the complexities of managing complications when they arise. It really is such a delicate balance nurses manage constantly.
It truly is. We've looked at how essential tools like ultrasound give us windows into fetal well-being, checking viability, growth, anatomy, and we've seen how serious complications, especially emergent infections, demand that nurses recognize signs quickly and intervene effectively. It all comes back to integrating your knowledge, meds, labs, the nursing process for safe, effective care.
So, thinking about all this,
Yeah.
as you, our listeners, get ready to step into your nursing careers, what's the big takeaway? What does this all mean for you? Well, it raises a really important question, I think. In this incredibly dynamic, often unpredictable field of perinatal nursing,
Hmm.
your absolute strongest asset, it's going to be your assessment skills.
Mm-hmm.
That ability to notice the subtle things, to recognize those red flag warning signs, maybe before anyone else does, and then to act decisively based on what you find. That can literally make a life-saving difference for both mom and baby. So the question for you is, how will you intentionally cultivate that sharp awareness, that clinical intuition, every single day in your practice? It's not just knowing facts, it's about seeing what they mean in real time.
Definitely something important to mull over as you prepare for clinical practice. We really hope this deep dive helps you feel more confident, more prepared, and ready to make that critical difference.